Auzubillahiminasyaitonirrajim. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Now we are going to move to our second part of the lecture on the therapeutic use of radiopharmaceuticals. So we're going to move to the hemophilic synovitis. So it is an intra-articular hemorrhage, which is the most common musculoskeletal manifestation, especially in hemophilia patient. Acute hematrosis is categorized by rapid swelling of the joint, which may be preceded by stiffness and also pain. So the resulting inflammation is known as a synovitis lah. So it is directly correlated to the chronic accumulation of the blood within a joint. When bleeding occurs within a joint, the collected blood breakdown product must be removed by the synovial membrane. So iron is a potent stimulus to the synovium. Abundant in the blood induces inflammatory reaction lah. So synovial membrane can absorb the blood products after isolated intra-articular bleeds. With repeated bleed in the same joint, this will overwhelm the synovial membrane's ability to do so. So it will desynovitis and increase the synovial volume, which termed as synovial hypertrophy. So more blood is required to wash out the blood debris from the joint. So the development of the rich network of capillaries will occur, and this will actually underneath the hypertrophic synovium to compensate for the shortage of the blood. And the new capillary network and hypertrophic synovium is prone to impingement by the joint surfaces. This will also increase the likelihood of repeated bleeding and cause the vicious cycle. Ultimately, it will lead to the cartilage and joint destruction. So from this, we can clearly see that the hemorrhage will increase the synovial inflammation. So the recurrent hemothrosis will have a cycle of synovial hypertrophy and synovial impingement. And then the direct synovial invasion happen with the enzymatic degradation will lead to the end-stage arthropathy. So the sign and symptoms of this is actually stiffness, tingling, pain, flex joint to reduce intra-articular pressure. So the joint will seem to look swollen, reddish, tender, as well hot, and then it will thicken the synovial membrane. So the treatment goal is actually to break the hematrosis cycle as soon as possible. And we have three types of the treatment that can be used. It is a surgery, chemical, or radiation. In terms of surgery, the pro of it is actually most of the synovium can be removed, but it will limit the range of motion. It will increase hospitalization, and high amount of clotting factor is needed, and it will give an exhaustive physiotherapy to the patient with a high cost. Whereas the drugs that can be used, such as rifampicin or steroid, it will minimal the invasion. It is inexpensive. Obviously, it is readily available and does not deteriorate on storage. Low cost with no hospitalization, but it will give a painful reaction to the patient, and it requires multiple injection of the procedures. For the radiation, it gives a minimal invasion, no hospitalization. Patient can come early in the morning and go back as a day care patient. Low cost with no clotting factors required in some areas. It requires a quick and simple procedures. However, it is radioactive and it decay on storage. So, radiosynovectomy, it is a method of treatment for several acute and chronic inflammatory joint disorders, and a small amount of beta-emitting radionuclide is injected into the affected joint. So, local form of radiation therapy, which first used by Fellinger et al. In 1952, is a treatment of resistant synovitis of individual joint. It has been accepted as an alternative to surgery. And then how does it work? Obviously through the intra-articular injection of the radionuclide in a colloidal form. So this radiosonavectomy, it is indicated for the treatment of joint pain arising from arthropathies, include the rheumatoid arthritis, spondyloarthropathy, persistent synovial effusion, calcium pyrophosphate dihydrate arthritis, as well as other inflammatory joint disease such as Lyme disease and Behcet disease. So what is the ideal isotope for radiosonavectomy? It need to be pure beta emission, so it will give a very effective ablation at the inflamed synovium. In terms of the shallow depth of penetration, hopefully it focuses the effect on the synovium while still avoiding radiation to other tissues, meaning we want to ensure that it's only happen at the synovium area and it will penetrate more than more to other areas surrounding the synovium. It has a moderate half-life because it allows gradual energy deposition and avoid immediate inflammatory reaction associated with the rapid decaying isotope. So three requirement is important. Radiolabeled particles should be distributed homogeneously in the joint space without initiating an inflammatory response. Binding between radionuclide and particle must be stable throughout radiosonavectomy. This can be determined by the radionuclide's half-life. The particle must be sufficiently small to be phagocytized, but it cannot be too small that it will leak from the joint. So the appropriate size should range between 2 to 10 micrometers. So we have our first radiopharmaceutical that used for radiosonavectomy in 1952, which is the colloidal gold, our Orium 198. Later, phosphorus 32 and dysprosium 165 were also used, but they had a major disadvantages with a high lymphatic transport, and the phosphorus 32, they have a long half-life of about 14 days. So now, currently there are three types that are widely used. First is yttrium 90 citrate or silicate, rhenium 186 sulfide, and also erbium 169 citrate. So the choice of between the three of these are directly related to the joint size lah. So mechanism of radiosonavectomy, it disrupt the inflamed or hypertrophic synovium with the use of direct irradiation lah. Following destruction, the synovium is expected to regenerate and be free of the disease. Other histological changes include a reduction of cellular infiltration and eventually sclerosis of the synovium. So our first radiopharmaceutical is the erbium 169 citrate. It is a pure beta emitter. It has the lowest tissue penetration, about 0.3 millimeter deep. It has the lowest energy of all, only 0.34 MeV. It has been used in the smallest joint, the phalanges of the fingers. So it's a small joint that we have in our body. So the half-life is about 9.4 days. The dosing is according to the table I give you all. Next would be the rhenium 186 sulfide. It has both gamma and beta with a moderate tissue penetration with about 1.2 millimeter deep. So this is why it can be used for the most joint, the moderate joint lah, because they are the moderate energy with only 1 MeV. So it can be used in the intermediate size joints such as wrist, elbow, shoulder, hip, as well as ankles. Half-life is about 3.72 days, and you can see the recommended activities at those joints as in table. In the next one would be the yttrium-90 citrate or silicate. So this one is very important, yeah. Bila you are because bila when you are saying about yttrium-90 for the radiosynovectomy, you really need to mention it is yttrium-90 citrate or silicate. Then only it can be referred to the radiopharmaceutical that's going to be used for your radiosynovectomy. Because macam if you are saying about yttrium-90 also, only, maksudnya yttrium-90 can be used for other purposes. It can be labeled with other things, so that it mean a nonsense if you're just saying about yttrium-90. So you've got to mention yttrium-90 citrate or silicate. So it has a pure beta emission with the deepest tissue penetration of 3.6 millimeter deep and highest energy of about 2.2 MeV. So this is suitable for the knees, a large joint and joints with greatly thickened synovium. It has half-life of 2.7 days and the dosage is about 5 to 6 millicuries. So this is an overview of those radiopharmaceutical. You can have a clear picture on their particle size as well as what type of emission they have and their energy, half-life, as well as the penetration min or max lah. And then what is it used for? So if you can see, there's also an additional of phosphorus 32 colloid, but you can see the particle size is very big compared to the others, and then we have a very long half-life of those P32, and this is the reason why it is not commonly used now. So for our MOH center, HKL is currently have the radiosynovectomy being done at their centers, and this year they started use erbium-169. From previous years, they meant to use yttrium-90 silicate as well as rhenium-186 sulfide colloid. And then they also have used P32 years back in 2009 when I first posted there in HKL. So this is a side effect of complications. They are quite rare. Complications are rare. The early complication is transient increase in pain, radiation synovitis in 14 days, radiodermatitis. It can be counted by flushing with the corticosteroid, and then septic arthritis. Long-term complication is the chromosomal aberration in circulating lymphocyte, chronic myeloid leukemia, which is extremely rare, radionecrosis, very rare, as well as malignancy is a potential theoretical complication, but has never been observed. Yeah, because we just use maybe because it's short follow-up periods to the patient who undergone this radiosynovectomy. So obviously precautions need to be taken while handling the beta emitters. We have to make sure the appropriate shielding is used. Use the syringe holders and syringe shield, L shield, vial shield. We must use low density materials such as plexiglass or perspex or to shield the isotope in order to prevent excessive formation of Bremsstrahlung radiation. And obviously we have to monitor and change the glove, disposables frequently if contamination suspected. So this is to avoid contamination and contact with the beta emitter. So now we are going to move to the bone pain. So we are focusing on the bone metastasis. It is a common complication in cancer patients. It is the spread of cancer to the bone, resulting in severe pain. So bone metastasis is found in 85% of terminally ill patients with breast, prostate, and lung cancer, and to a lesser extent with other malignancy. Palliation of bone pain in this patient is the common goal to improve the quality of life. The radionuclide therapy in bone pain palliation is based on the avidity of various radiopharmaceuticals, preferentially localizing in bone, such as phosphorus 32 orthophosphate, strontium 82 chloride, and samarium 153 EDTMP. So we now want to look into the phosphorus 32 sodium orthophosphate. Use the phosphorus 32 decay by beta emission with a half-life of 14.3 days. It has maximum beta energy of 1.70 MeV. So the dose approximately about 6 to 12 MCI administered intravenously, and often multiple administration are made based on the response to the initial treatment. So the mechanism of action, since it is incorporated into the structure of DNA and RNA, these structures are damaged by the beta radiations lah. Following IV administration, 85% of the injected dose is accumulated in the hydroxyapatite crystal, and the remainder localized in the non-osseous tissues. Bone marrow is the most seriously damaged tissues by the phosphorus 32 radiation. Frequently, androgen is given for a week prior to administration of P32 to enhance the bone uptake of the tracer. The response rate of phosphorus therapy is about 80%, and the mean period of response is about 5.1 to 2.6 months. And the common side effect is hematologic toxicity due to bone marrow suppression. Occasionally, an increase in bone pain, bone flare is seen, which is primarily due to androgen given prior to the P32 administration. However, P32 therapy has not been accepted widely for palliation of bone pain because of the myelotoxicity, so it is not commonly used lah. So now we are going to move to the strontium 89 strontium chloride. We've got this Metastron GA Healthcare with a physical half-life of 50.6 days, biological half-life of 4 to 5 days. It decays by the emission of beta particle with a maximum energy of 1.43 MeV lah. So indication obviously for relief of bone pain due to metastasis from various cancers. The dose is at approximately 4 MCI injected slowly over a period of 1 to 2 minutes. So initial relief of pain is usually noticed within 3 days of administration, but it may be as late as 25 days. The mean duration of pain relief is of the order of 3 to 6 months, and therefore retreatment with strontium 89 may be considered every 3 to 6 months. After IV administration, it localized in reactive bone and excreted in the urine about 80%, while in the feces about 20%. 30 to 35% of the injected dose remain in normal bone for 10 to 14 days post-injection. However, the retention in osteoblastic areas is as high as 85 to 90% at 3 months post-injection. Patients should have a platelet count of at least 60,000 and a leukocyte count of 2,400 at the time of administration. In terms of ADR, myelosuppression may occur particularly with higher dosages, thus reducing the platelet and leukocyte count by almost about 25 to 30%. Complete remission of pain is found in 5 to 20% of the patient after strontium 89 treatment. Almost 80% experience some relief of pain from osteoblastic metastasis, and in 10% of the patient, there is an initial increase in bone pain within 3 days of therapy that subsides in about a week. So it's going to be a flare effect to the patient. Now we're going to move to the samarium. Samarium 153 EDTMP is a beta emitter, maximum energy of 0.81 MeV, decay with a half-life of 1.9 days, emit a gamma ray photon of 103 keV. So it is also suitable for the scintigraphic imaging. So indication is the relief of bone pain due to metastases from various cancer. The dose is about 1 millicurie per kg lah. So it is rapidly cleared from the blood and avidly localized in the bone. Almost 35% of the injected tracer is excreted in the urine by 6 hours post-injection. It also appears to be deposited as an insoluble complex on the hydroxyapatite crystal. So relief of pain is found in about 65% of the patient within 1 to 11 months and may last for a year. Further relief of pain is achieved with repeat treatment. Myelotoxicity is observed in this patient and is related to the dosage administered. Next, we have this rhenium-186 HEDP, which is formed by combining a diphosphonate useful for bone pain therapy, etidronate with a beta emitter. It is another agent that may be useful for the palliation of bone. It emits a gamma ray, so useful for the imaging and lesion identification. So it localized to the bone with approximately about 14%. The remainder is rapidly cleared with roughly about 70% of the dose excreted in the urine 6 hours after the injection. Now we are going to move to the selective internal radiation therapy, the SIRT. It is a targeted treatment for liver tumors that delivers a million of tiny radioactive beads called microspheres. It will be directly to the liver tumors. So the liver, it is a unique organ that has two separate blood supplies. The major artery, if you can see with the red color, to the liver is the hepatic artery. It provides 20% of the blood supply to the liver, while a large vein, the portal vein in the blue color, it supplies the remaining 80% of the blood. In contrast to the normal liver, the cancer involved the liver, it will receive the 80% of its blood supply from the hepatic artery. So this selective internal radiation therapy, it takes advantage of this difference of blood supply between the normal liver and cancer, which involve the liver. So this radiation treatment is delivered through the artery to the liver. The hepatic artery will actually preferentially seek the cancer with the less radiation dose to the normal liver lah. So yttrium-90 resins microsphere, it is a medical device used in selective internal radiation therapy SIRT for liver tumors. These microspheres, they are permanent implant and they for single use only. The biocompatible resin microsphere labeled with yttrium-90 have a median diameter of 32.5 microns. It ranges between 20 and 60 microns lah. Yttrium-90 ni, it has a high energy beta emitting radioisotope with no primary gamma emission. The maximum energy of the beta particle is about 2.27 MeV with a mean of 0.93 MeV. And the maximum range of emission in the tissue is 11 millimeter with a mean of 2.5 mm. The half-life is about 64 hours. So following administration, 94% of the radiation is delivered in 11 days. So means these properties of the resin microspheres means that these microspheres, they lodge preferentially in the microvasculature surrounding the tumor, maximizing the tumoricidal effect and minimize the effect on the healthy liver parenchyma. So this is how it been administered. It's gonna be administered under local anesthesia by a special who make a small incision, usually into the femoral artery near the groin lah. in the image A, yeah, picture A. So it guides a microcatheter to the pre-specified site in the hepatic artery as identified during the pre-treatment planning. So you can see here in the picture B. So then it will administer the microsphere through the catheter in this picture C. So it is recommended that patients have a scan to confirm the placement of the microsphere. Patient then should be monitored for a few hours, and most patients are discharged within 24 hours. So just now is the use of Surtax, yeah, one of the yttrium-90 microsphere that is available. So another product is yttrium-90 TerraSphere. So beta emitter, obviously, because it uses yttrium-90, it has the same average energy and also average range, as well as the half-life. So indicated for the treatment of unresectable hepatocellular carcinoma in patients who are capable of having placement of a hepatic arterial catheter. So the microspheres are administered directly to the tumor through the hepatic artery catheter, where the microsphere are trapped in the tumor, and the beta radiations from the yttrium-90 will kill the tumor cells along with some normal cell, but it has been reduced to the normal cell. So this is an example of TerraSphere. More or less is the same method how it been delivered to the liver. So this is some more information about the microsphere resins. In prior to the treatment, I would like to draw your attention that the patient is evaluated for the extent of AV shunting to the lung. By administering, so we administered 2 to 4 MCI of technetium MAA into the hepatic artery. Then we do the gamma camera imaging. So the doctors will calculate how bad the AV shunting to the lung is. Yeah. So in the absence, if the absence of extra hepatic shunting, then only the TerraSphere is going to be administered lah. So the recommended dose to the liver is between 80 gray to 150 gray. So the activity required is calculated using the formula. The mass of the liver is estimated from the CT or ultrasound scan. The net activity administered is determined from the initial vial activity minus the waste activity. Then it is corresponding to the radiation dose to the liver lah. It will be calculated then. So in one clinical study, 22 patients were treated with a mean activity of about 105 millicurie, delivering a median liver dose of about 104 gray. So the result shows survival of minimum 49 days to maximum of 1265 days. So in another study, the median survival following the treatment of HCC with TerraSphere was 3.6 months at doses of 80 gray and 11.1 months at doses of more than 80 gray. Adverse effect from the TerraSphere treatment include elevated bilirubin, SGOT, SGPT, and alkaline phosphatase, ascites, as well as abdominal pain. So this one is about the Surtax that you can actually reach later. And this is an example of the Surtax radioactive radiopharmaceuticals that is available. Obviously, same as the TerraSphere, the AV shunt is also need to be calculated. If the shunt is between 10 and 20%, the dosage is adjusted corresponding to the extent of shunt, whereas treatment is not given if the shunt is greater than 20%. Okay. Surtax are then administered from the single dose vial to the tumor through the catheter, as I've mentioned earlier. So this is how the individual dosage is calculated. If more than 50% tumor involved, dosage is about 81 mci. If 25 to 50%, 68 mci, and if less than 25%, the dosage is about 54 mci. Further reduction in dosage is made depending on the extent of lung shunting. So 10 to 20% shunting, we need to reduce to 20%, 15 to 20%, 40% reduction. If it is more than 20% shunting, we shouldn't proceed the treatment. So in general, 27 millicurie provide approximately about 50 gray radiation dose. Complete and partial response has been reported in a 3-month interval, and progression of the tumor is delayed significantly when fluoxuridine and Sirtex are given together for the treatment. Common adverse effect is the fever, mild increase in liver enzyme and bilirubin, abdominal pain, nausea, vomiting, and diarrhea. Potential serious adverse effect due to the high radiation is the acute pancreatitis, radiation pneumonitis, radiation hepatitis, as well as acute cholecystitis. So now we are going to move into the radioimmunotherapy. So RIT uses monoclonal antibodies directed against specific tumor antigen labeled with a particle emitting radioisotope to deliver radiation directly to the tumor. Radioimmunotherapy combines the synergistic effect of both radiation and also immunotherapy with manageable local and systemic side effects. So the characteristic and complex interaction between the tumor, the host, radionuclide, and the antigen-antibody complex will determine the effectiveness of the RIT. So it has an established role in the treatment of lymphoreticular malignancy, but it has not proven effective for the treatment of solid tumor due to the limitation with antibody penetration within the central portion of the larger tumor. So we now want to see a bit on the antigen. So antigen is a molecule that stimulates an immune response. It is either protein or polysaccharide on the cell surfaces, and it has many different types of tumor antigen, whether it's a tumor associated or tumor specific. Then we're going to go to the antibodies. It's a large Y-shaped protein. It identifies and neutralizes the antigen, which induces apoptosis and then the cell cycle redistribution. And multiple antibodies for every antigen. So this is how monoclonal antibody has been generated. It's a highly specific. It's a clone of a single cell, fused B cell and tumor cell, and then it can be screened for the antibody production. So if we want to have a further on the nomenclature of monoclonal antibody, so we can see if it's a 100% mouse with a 0% human antibodies, it will call something like OMAP, yeah, ibritumumab, tositumumab, tetulumumab. And if chimeric, whereby it's about 65% from the human, it comes out as ZIMAP, as for example, our rituximab. And then if it is a humanized antibody with more than 90% of human protein, it will call as ZUMAP, trastuzumab, as well as lintuzumab. And then we will also have 100% human antibody, which is a UMAP. So radioimmunotherapy, it adds a radioactive molecule to the monoclonal antibody. So what is lymphoma? It's a malignant transformation of lymphocyte affecting lymphatic system, but can affect any other solid organ. So typical presentation is the lymph node enlargement, splenomegaly, as well as bone marrow involvement. So type of cancer, it depends. If carcinoma, the cell that cover internal and external body surfaces lah. We have leukemia for the blood cells, lymphoma, lymph nodes tissues, sarcoma cell, which is support the tissues of bone and muscles. Yeah. So we're going to focus on the RIT and non-Hodgkin lymphoma. We have the specific antigen targeted, which is the CD20. It's a tumor associated, does not shed or internalize. And the isotope that can be used with this is actually yttrium-90 with a half-life of 64 hours, and it has a pure beta emitter. Or we can also use the iodine-131 with a half-life of 8 days. It have beta and gamma. So it vary in the conjugation. How are we going to conjugate the isotopes with the monoclonal antibody? Yeah. So the first one that we have is actually yttrium-90 ibritumumab deoxyribonucleic, or it is called Zevalin. It was first approved RIT by the FDA in 2002. So the indication is for the relapse of refractory low-grade or follicular B cells non-Hodgkin lymphoma, previously untreated follicular NHL who achieve a partial or complete response to first-line chemotherapy. So it used a murine monoclonal antibody with the yttrium-90 with a penetration of about 5 to 10 millimeter and a half-life of 2.67 days. Okay, and we have this DTPA as a chelating moiety to actually chelate the yttrium-90 to the monoclonal antibody. And this is the process of attack, the schematic diagram of how it been attacked in the bodies. So, our Zevalin has decay of beta emission, half-life of 64 hours, and then high energy beta ray with an effective path length of 5.3 millimeter. It has an anti-CD20 antibody. It is an optional but promising treatment of relapse or refractory low-grade follicular or CD20 antigen expressing transform beta cell and B cells and HL in this patient. The dosage is based on body weight and baseline platelet count. It's about 20 to 30 MCI with a maximum limit of 32 MCI. Okay. Both rituximab and Zevalin target the white blood cell, including malignant B cells involved in the disease, which results in the significant tumor shrinkage. The overall response rate was found to be about 74 to 80% in about 2 months after therapy in patients who fail in response to chemo. Common side effect is a flu-like symptom as well as a marked reduction in blood cell count. So I would say the Zevalin is the commercially available, but in terms of use in Malaysia is quite expensive. It's very expensive. If I'm not wrong, HKL has used it once. It's so long time ago, but currently we are not focusing in having it because of the expensive treatment to the patient. Then we have this iodine-131 tocilizumab, or we call it as Bexa, for CD20 antigen expressing refractory. It's a low-grade follicular NHL used as a single course of regimen. It is not used for the initial treatment of CD20 positive NHL. It is contraindicated in pregnant women. After IV administration, of Bexa, its blood clearance in NHL patient is slow but become faster in patient with tumor burden, splenomegaly, and bone marrow involvement. The median total blood effective half-life is 67 hours. The whole body clearance of Bexa is about 67% of the injected dose in 5 days, and 98% of it appeared in the urine. 1 day prior to the start of the protocol, the patient received the SSKI or Lugo solution to block the thyroid and continues through 14 days post therapeutic dose. A total of 450 milligram cold tositumomab from 2 vial is infused IV through a catheter over 60 minutes, followed by infusion over 20 minutes of a dosimetry dosage of 5 mci. That contains about 35 milligram of cold antibody lah. Whole body counts and images are obtained by a gamma camera within 1 hour at 2 to 4 days after urination and 6 to 7 days after urination. The data are used to calculate the therapeutic dosage of Bexar required for the patient. In the treatment step on day 7, 450 milligram of cold tositumomab is infused IV over a period of 60 minutes, followed by infusion of the therapeutic dosage of iodine 131 tositumomab about 35 milligram over 20 minutes. So advantages of the RIT is actually precision of the treatment because it gave less damage to the healthy tissue, and the irradiation of nearby or unbound cells, it will actually less effect. Patient comfort is just 1 hour intravenous procedure with outpatient administration because it used the beta properties for the yttrium 90. So in terms of yttrium 90 label Zevalin, 80% overall response with that yttrium 90 Zevalin, 34% complete response, and 32% still in remission 3 to 4 years later. So I would like to draw your attention that Zevalin is still in the market, but yet Bexar has already none in the market. So for the RIT, it is the yttrium 90 label ibritumumab that is available for be used. But in some center, they are labeling themselves. From example, in Korea, they are actually labeled iodine 131 with the rituximabs. So the labeling can be done by the pharmacist on site. And this is also what we are looking into, most probably trying to actually label iodine 131 with the rituximabs at our local setting for it to be used to our patient. So that is the end of my lecture. I hope that you guys can focus more on the common radiopharmaceutical that been used in the therapeutic treatment. The most important is the radioiodine, iodine 131, which is most of the centers are handling it. Whether it's meant for the low dose iodine or high dose iodine, but in some centers, they are just focusing on the low dose for the thyroid disease cases. But I would say that most centers are handling the radioiodine 131. In addition to this, we have the radiosanavectomy using all those 3 radiopharmaceuticals at the Hospital Kuala Lumpur, followed by the CERT. It's either our Certex or TheraSphere that is commonly used in our Institute Cancer Negara setting. So I hope that you really understand those lectures that I give. If you have any question, you are feel free to contact me through WhatsApp, through telegrams, or even through the email that you have. So with that, I